like one of the images that he showed was a video of through the peephole of direct ophthalmoscope performing a distant direct ophthalmoscopy, in which we actually visualize that central PSC cataract. So that is one thing that he very wonderfully captured, and that we can actually do. So those are the arts that we have been actually failing to transmit to our undergraduates, who can actually be our workforce for this all this screening thing. So that actually is a part of their curriculum as per NMC. They have to learn it. So if they are learning it, they can actually utilize it in the community whenever they are having their postings. So next talk is on the ABC of vision threatening glaucoma screening, Amsler beams confrontation. So that those are the ABC, and we have added a digital device as the ABCD of it, but mainly conforming to the rural settings and the tribal settings, ABC are the ones that are of prime importance. So no financial disclosures. Glaucoma, we already know the impact worldwide, the magnitude, the undetection rate, and okay, the numbers are staggering, so I won't just go into the numbers. The Indian scenario definitely is more alarming, with prevalence of 2.7 to 4.3, blindness 1.2 million, and 5.5% of total blindness, and is a leading cause of irreversible blindness. So that is one point that actually is why that we need to screen it early. We already know. So we have been conducting World Glaucoma Days and screening camps. That screening should be done. So that is the part we actually know. We know how to diagnose it. We know how to treat it. But the gray zone is the screening and the awareness part, which still is lacking as per the literature also. So awareness, as one of these reports mention, awareness is like only, okay, so it was like very less in the Indian population, and undiagnosed glaucoma is again 90% in the Indian population. That is what data suggests. So having said that, what should be done? So traditional community based screening, though we may not like to accept it, but yes, it has mainly largely been IOP based. So that is how we screen for glaucoma mostly. So it's only IOP we take, and okay, ठीक है, IOP बढ़ा हुआ है तो glaucoma के लिए करते हैं, नहीं बढ़ा हुआ है तो नहीं करते हैं. That is mostly in large parts. I think there is no denial. Mainly in sub centers, they definitely modify it, especially if it's a research institute, they definitely add on to those things. And some people, like if they have a trained man force, they actually go for a direct ophthalmoscopy, undilated direct ophthalmoscopy also. So those are the things, like again, not done in silos, but not overall. So that is mainly the main bane of glaucoma screening in the Indian settings, and it has already been documented, like way back in 83, that screening with tonometry does not appear to be warranted at all, not cost effective, because you end up screening and referring more patients rather than who you want to treat for it. Okay, so what is lacking is, so as I said, tonometry alone is inadequate. Visual field assessment largely lacking. Optic disc examination, yes, partially it is done. So applying those methods, HMIS mobile app, on spot, so that we have already dealt with, so I won't go into the details of it, how you capture the epidemiological data of the patient and the vision screening part. So coming straight away to the glaucoma screening part. So okay, so the ABCDs, the A stands for the app-based vision screening that we already discussed. And the second part is Amsler. So Amsler has actually been tried and tested, but we do not again use it. Again, it is not a very time consuming process. You won't be able to detect early glaucoma. But in Indian settings, actually, early glaucoma, if you detect, that's a wonderful thing. But at least you should be able to screen the vision threatening glaucoma, and that is what Amsler can easily do for you. So that is our main take-home message in these talks, that for glaucoma, for diabetic retinopathy, at least you should be able to screen the vision-threatening parts. If you are unable at least to screen for the early detection, that is okay. If that can be done, that will be great. But since you have a shortage of ophthalmologists, retina specialists, glaucoma specialists, so at least we can cover this part. So Amsler is something that we can do. Beams, eclipse sign in torchlight, again, which is taught to the MBBS students. They learn it very well, and that can be applied actually. And confrontation, again, same thing, which is a part of their curriculum. So vision screening we have done. Now this is now again, these recordings for this purpose, we haven't actually done, we have done it in our setting rather than the camps for a proper documentation of it. So Amsler, the technique is told to the patient, and we just on a mobile we get the proper dimensions of the Amsler, use the photo app so that patient can actually draw कि आपको कहाँ क्या दिख रहा है, and the patient actually draws the things as will be seen in this video. So marking the boundaries where the patient sees it, any dark spots, scotomas or wavy lines, whatever is visible, the patient can actually mark it. So yes, again, like this will be, sometimes it takes a longer time because the patient comprehension of that thing, what has to be done, may take a longer time. But eventually the patient understands what is to be done and does that. Again, in all these, we have only used our nursing officers, residents, and MBBS and nursing students, MBBS students and nursing students for documents. So this is what the patient actually drew for the marking the superior edges. Inferior, I think we did not capture. Now these are the MBBS students for whom actually we have done a video-based clinical examination teaching. So they are performing the eclipse sign. Because angle closure glaucoma, if it is not an acute congestive glaucoma, is often missed. You do not actually look for it. You look only for IOP, especially in the screen setting, community settings. So at least you can do, obviously, if you have a handheld slit lamp, you can do a Van Erichs. If you have a Perkins, you can do a proper AT. But in our settings, we already know there are limitations. So at least you can do this thing for eclipse sign. And if you see like a very shallow, as I said, vision threatening, which can convert to angle closure attack. So those patients you can definitely screen. Confrontation again, now this is like very reliable. So we have been able to publish one like biomedical student who performed it for a patient who came to the like a community OPD, third year student. She was able to pick up based on confrontation. The patient was actually complaining, ठीक है मुझे थोड़ा बहुत side का कम दिख रहा है. She documented it and it was like a pituitary tumor which is actually published. So expanding the, so that was like mainly for the tribal settings and very low resource settings where we can apply those ABCs, extending it to these apart from app and Amsler. As I said, if you have resources, you have the funds, portable Perkins, that nothing can replace an applanation. Like till date, we are mainly doing whatever we are doing is on the basis of Shios mainly. But yes, one more thing on the D part is we can add a digital tonometry again to at least detect those higher IOPs. And digital screening is what is left that we'll be talking about. So one part has already been covered, like using the smartphone and a 90D, you can actually visualize the disc very well, and that can be like screened real time. So this is for the same instrument that was used for diabetic retinopathy. We used it just in our World Glaucoma Week celebration, and we were able to like pick up those findings. So this is again a very easy app. You just undilated fundus, so you can have those photographs. So patient compliance actually increases a lot. So there is no dilatation involved. The patients actually say कि ठीक है हमारी screening कर दो. Once you say कि dilate करेंगे, 1 घंटा बैठना पड़ेगा, blurring होगी. So they say okay मेरे आँख में तो कुछ है ही नहीं, क्यों इतना डरा रहे हो? So that happens a lot actually. ठीक है. So once you do it with an undilated fundus, apart from the fundus, you get a report. So that report again is a very reliable one. The studies have been done, published in the Eye Journal, and with a good sensitivity of around about 85 to 90% sensitivity and specificity for these devices. Okay, so they actually give you the referable glaucoma. So yes, this once it comes in those fonts, orange, red, the patient knows, okay, ठीक है अब मुझे तो दिखाना है, something is wrong. Again, as I said, percentages and figures actually help to convey more impactfully rather than just mentioning कि आपका IOP बढ़ा और you have some problem with it. So that was the process. We just select the clear images and it will self-generate a report. So the AI-based reporting is like good. and these instruments actually the prices have come down reasonably. So I think this can be like a very good tool for future proper glaucoma screening methodology on a national scale. So these again, as I said, are performed by our junior resident, MBBS students and our senior resident. And this is something actually I came across yesterday in one of the stalls. So as I said, for the HMI's documentation, we can use the QR. So we can actually use the QR also for the awareness part. So this is like one scan QR. I tried to scan it, and this is what actually it comes up. So it actually, once the patient scans it, you get everything regarding awareness regarding. So this slide actually put up yesterday when I visited the stall. So the QR based thing, not only for epidemiological data, but for patient awareness, that can have a very good impact. And like people love to scan QRs, even children love to do that. We know that. So I think that can be a wonderful thing. So take home message will be enable. So what we need to do is have a proper and a vast workforce capacity building for proper screening. So where can we get them from is mainly from the MBBS students and nursing students who can be easily taught those easy methods which are in their curriculum. So if they can be trained, then definitely we can have a very good workforce, at least for the screening of vision threatening glaucoma. That is what our goal is for these talks. Okay? So it can be performed reliably by non-ophthalmic healthcare force, as we already told. And yes, so telescreening and awareness can be bettered. Thank you. So that concludes actually our talk, this talk on smart screening. If there are any questions, we can take up that. Like ma'am asked about the availability of that is freely available with all the the advices and how to perform it, that can be actually be implemented. If there are any other questions, please. Any concluding remarks from Samantha sir, please?
Thank you, Professor Onkar. It's really a very informative instruction course and very much practical to implement in each and every corner of the country. I'd like to request each and every participant to disperse these ideas to their fellow faculty members as well as all the hospitals and community eye health personnel. By the term community eye health personnel nowadays, we like to make the broad term. The state program officers in ophthalmology, each and every state is there. There are so many corporate hospitals, private hospitals, voluntary eye hospitals under NGO. You can disperse these ideas and our government sector. What I have told at the very beginning of my talk and what Professor Onkar has elaborated all the way, to do any work, we must have got need assessment study. And this smart technology is the best way for the need assessment. Then we can proceed for further planning and implementation. Thank you very much.